Prolonged labor is a frequent cause of maternal and perinatal death and disability. It can result in neonatal asphyxia, cerebral palsy, postpartum hemorrhage, uterine rupture, obstetric fistula, and infections. Prolonged labor means that the birth progresses too slowly. Causes. Prolonged labor can be caused by the 5 P's. Power. At normal birth, there are 3 to 5 contractions, each lasting at least 40 seconds in 10 minutes. Pelvis, or passage, is rarely the cause of prolonged labor, but if the woman has a malformed pelvis, or a pelvis that is not fully developed due to young age or malnutrition, consider delivery at a referral hospital. Passenger. The normal presentation is cephalic, and the normal rotation is occiput anterior. Sometimes there's a malposition, like occiput posterior. Sometimes the head can be bent to the side, or sometimes there's a malpresentation, for example, brow or face. Psyche. Anxiety and stress can cause contractions to weaken or stop. Make sure the woman feels in safe hands and is treated respectfully and gently. Passing urine. Since a full bladder can complicate the descent of the fetal head through the pelvis, it's important to remind the woman to pass urine every other hour throughout the active phase, first stage of delivery. Also ask the woman to pass urine before starting to push. Prolonged first stage. The latent phase of the first stage starts when there are regular, painful contractions. If there are regular contractions for 8 hours or more, and the cervix is still dilated less than 4 centimeters, consider prolonged latent phase and send the woman to a referral hospital. However, prolonged latent phase is often confused with false labor, where contractions weaken after a while. Consider urinary tract infection as a differential diagnosis. The active phase of the first stage starts when the cervical dilatation is 5 centimeters. At this point, the partograph should be started. Plot the cervical dilatation on the alert line and note the time. After 4 hours, perform the next vaginal examination and plot the dilatation. If the progress in dilatation is to the left or on the alert line, the progress is normal. But if, for instance, the partograph is started at 5 centimeter dilatation and only progresses to 7 centimeters after 4 hours, then the labor is prolonged and the dilatation is now between the alert and action line. In this situation, take the following actions. Empty the bladder. Get the woman up and walking, or even dancing. Amniotomy, also for HIV-positive women if on antiretroviral therapy. At prolonged labor, you reassess in 2 hours and refer if there's no sufficient progress. Prolonged second stage. The second stage of labor starts when the cervix is fully dilated, 10 centimeters. The head should now descend to the pelvic floor. It's best to wait with the pushing until the head is at the pelvic floor. But if it is not after 2 hours, pushing can be started. The pushing is the most stressful and dangerous part of labor. At strong contractions, pushing should not last for more than 1 hour. If cephalic presentation and the head is not palpable more than 1/5 over the pubic bone, a vacuum extraction could be attempted after 1 hour. Vacuum extraction is a basic emergency obstetric and neonatal care signal function, and should therefore be mastered by any skilled birth attendant. The most important indications for vacuum extraction are prolonged second stage, maternal exhaustion, and fetal distress. In the second stage, the fetal heart rate should be assessed after each contraction. If the fetal heart rate is above 180 or below 100, roll the mother to the left side and continue to assess fetal heart rate. If it is unchanged after a few minutes, delivery must be expedited. To perform vacuum extraction, the head must be well engaged, cervix fully dilated, membranes ruptured, and the gestational age must be 36 weeks or more, although pregnant women at a gestational age of less than 37 weeks should be delivered at a hospital. The risk of perineal trauma and minor trauma to the head of the baby is increased at vacuum delivery. Following is a structured approach to vacuum delivery. Ask for help. Address the patient. Tell her and her companion what you're about to do while you continue to prepare, and tell her that you need her to cooperate and keep pushing when there's a contraction. Abdominal palpation. The head should not be palpable more than 1/5 over the pubic bone. Bladder empty. Check that cervix is fully dilated. Contractions. There must be contractions to succeed. Determine position. Locate the posterior fontanelle, triangular shaped, with your index finger. This is important information before you can place the cup correctly. Equipment ready. Delivery set. Oxytocin for intramuscular injection to the mother after delivery. Towels. Neonatal resuscitator and vacuum extractor. Flexion point. Most cups are 3 centimeters from the center to the edge. Place the edge of the cup at the tip of the posterior triangular fontanelle. Feel for vaginal tissue between the cup and the fetal skull before and after applying suction to avoid trauma to the vagina. Gentle, steady traction with no rocking during a contraction, and with the first contractions downward. During the following contractions, more upward. Halt in between contractions. Halt and abandon if 3 pop-offs or if 3 pulls show no progress, or if delivery is not achieved 30 minutes from application. Intact perineum. When the head is delivered during the next contraction, protect perineum with one hand. Squeeze the index finger and thumb together at the posterior part of the head to prevent stretching of the perineum, and lift the head with your third finger upwards and away from the perineum, while the other hand keeps the head from coming too fast. An incision is only rarely needed. When the jaw is reachable, release the vacuum and remove the cup. Remember that it's not recommended to apply manual fundal pressure to facilitate childbirth. A prolonged second stage can often be managed with vacuum extraction. If the procedure is not possible or fails, the woman should be referred to a facility where a cesarean section can be performed.